Etiology of fecal incontinence. In this lesson, we will review anatomy and physiology of the gastrointestinal tract and delve into factors that contribute to a person's developing fecal incontinence. Our learning objectives include identifying different causes of fecal incontinence and explaining the physiology of defecation and fecal incontinence. Fecal incontinence is a problem that affects all ages. The numbers listed on this slide are somewhat staggering. Incontinence, whether fecal and/or urinary, is the number 1 or 2 reason an individual is admitted to an extended care facility. As you can see, it is not only a problem affecting elderly. When speaking about fecal continence issues, it is important to have the terms defined, so let's start here. We all now know what is meant by defecation, with the formal definition stating it is the forceful expulsion of fecal material from the colon. When one speaks about fecal continence, one is not always cognizant of what is involved to keep a person continent. Not only does a person have to have the mental capacity to correctly interpret the signals to defecate, but the colon, rectum, pelvic floor, and neurological systems need to be working in concert to help the person maintain that fecal continence. This lesson will touch upon each of these areas so that you will better understand what is involved. So, just a quick review of the definitions then. Defecation is that forceful expulsion of fecal material. Fecal continence is the ability to retain feces until the socially appropriate time and place for elimination. And fecal incontinence is the involuntary release of a person's rectal contents against his or her own wishes. The photo on this slide illustrates the organs of the digestive system, and you can see that the majority are located in the abdominal cavity. Mechanical and chemical breakdown of food begins in the mouth as one chews food, mixing it with saliva as this food mass continues from the mouth to the remainder of the alimentary canal. From the oral cavity, the foodstuffs proceed down through the esophagus to the stomach. The stomach serves as a reservoir, and stomach secretions will continue breakdown of the protein molecules through the mechanical action of churning and mixing, distributing acids and enzymes, which further assist in the breakdown of the food molecules. Certain substances such as aspirin, alcohol, and caffeine are absorbed directly from the stomach. The parietal cells of the stomach secrete intrinsic factor, which is necessary for the later absorption of vitamin B12. The partially digestive food, called chyme, passes then into the small intestine. The small intestine is about 22 to 23 feet or 6 to 7 meters in length. It is divided into 3 parts: duodenum, jejunum, and ileum. Its primary function is to digest and absorb nutrients and fluids. Pancreatic secretions, as well as bile, help to neutralize the acidic nature of the chyme. Bile emulsifies fats within the duodenum, allowing for further fat breakdown. The majority of nutrient absorption occurs in the jejunum, where the villi, or minute finger-like projections and circular folds called plicae circularis, greatly increase the absorptive capacity of this portion of the small bowel. Each person will need to have about 150 centimeters of small bowel from the ligament of Treitz in order to prevent short bowel syndrome. In other words, about 150 centimeters or 5 feet of small bowel is required in order to absorb enough nutrients to sustain life without supplementation. The ileum also assists with nutrient absorption. The terminal ileum, which is the last 100 centimeters or 3.5 feet of the small intestine, is the only area of the body where over 95% of bile salts are absorbed. This is also the only area in the intestine where vitamin B12 intrinsic factor complex is absorbed. Disruption in this portion of the ileum does not allow for reabsorption of bile salts, which will alter digestion and absorption of the fat in the jejunum, resulting in diarrhea. In all, approximately 6,700 milliliters of intestinal juices are secreted each day, with all but 150 cc's reabsorbed. The colon begins at the terminal ileum and ends at the rectum. It is 4 to 5 feet in length, or approximately 122 to 153 centimeters in length. It has 4 distinct layers: mucosa, submucosa, muscle layer, and serosa. The ileocecal valve is the entry point from the small intestine into the colon, and it controls the release of small bowel content into the cecum. It also prevents the backward flow of colonic content back into the small intestine, thus protecting the small bowel from contamination of colonic bacteria. The colon is divided into the following segments: cecum with attached appendix, followed by ascending colon, transverse colon, descending colon, and sigmoid colon. The transverse colon is the primary site for mixing and storing the fecal mass. Stool at this point is a semi-mushy mass. It is slightly longer in women than men. The superior mesenteric artery supplies the cecum, right colon, and transverse colon up to the splenic flexure. The inferior mesenteric artery supplies the descending and sigmoid colon. The functions of the colon include absorption of water, collection, concentration, and transport of waste material, and elimination of that waste. Colonic bacteria play a vital role in metabolism of bile salts, lipids, and certain drugs, and synthesis of vitamins K and B, among other functions. This bacterial action is the main producer of intestinal gas, and most of the bacteria in the gut are anaerobes. Digestion in the colon depends on presence of bacteria in the colon. Colonization starts in infants and occurs primarily in the cecum and ascending colon. There is much discussion today about prebiotics, probiotics, and symbiotics. Probiotics are the good bacteria that help keep one's digestive system healthy by controlling growth of harmful bacteria. Examples of foods containing probiotics would be yogurt, sauerkraut, miso, and fermented soft cheese such as Gouda. Prebiotics are carbohydrates that cannot be digested by the human body and serve as food for probiotics. Prebiotics are found in asparagus, Jerusalem artichokes, bananas, oatmeal, and legumes. Symbiotics refer to dietary supplements that contain both pre- and probiotics. There is no food substance that contains both of these agents. There are 3 characteristic anatomic findings that differentiate the colon or large bowel from that of the small bowel and rectum. First are the tinea coli. The colon maintains the usual layers of the bowel wall for its entire length, but has 3 thickened bands of longitudinal muscle called tinea coli that start at the appendix and extend to the rectum where they coalesce. The haustra are the outpouchings of the bowel wall caused by the relative shortness of the tinea coli and are separated by placae semilunaris. These haustra give the colon its typical radiographic image. Finally, the epilopic appendages are appendages of fat that hang off the antimesenteric serosal aspect of the colon. The colon has some areas that are fixed in a retroperitoneal position, which are the ascending and descending segments, and other segments that are intraperitoneal and more mobile, including the cecum and transverse and sigmoid colon. The rectum is much shorter than the other parts of the intestine, measuring only about 12 to 15 centimeters or 6 inches in length. It extends from the sacral promontory to the anal rectal ring It has three curves corresponding to the three valves of Houston that divide the rectum into three parts: upper or superior, middle, and lower or inferior. The upper portion of the rectum is intraperitoneal, and the lower part of the rectum is extraperitoneal. The proximal rectum is supplied with blood by the inferior mesenteric artery, while the middle and inferior portion of the rectum are supplied by the middle and inferior hemorrhoidal arteries. The anal canal is the outlet from the rectum to the anal verge or anus. It is approximately 3 to 5 centimeters or 1 to 1.5 inches in length. It is usually closed at rest so that continence can be maintained. The puborectalis muscle swings or loops around the anal canal, which creates a 90-degree anal-rectal angle and helps maintain continence. The dentate line is located midway down the anal canal. It is in this area that columnar epithelium proximal to the dentate line morphs into squamous epithelium distal to the dentate line, and this area is known as the anal transition zone. Also, sensory receptors in the distal anal canal are able to differentiate if rectal contents are solid, liquid, or gas, which has obvious implications when discussing continence. This highly innervated area is known as the anoderm. The anal verge is the dividing area between anoderm and perianal skin located at the anus. The anus is a very complex area and responsible for maintaining continence of gas and stool. Continence results from lateral compression of the pubococcygeus muscle, circumferential closure from the internal and external anal sphincters, and angulation from the puborectalis muscle. There are a variety of different tissue types that make up the anus, and it is therefore susceptible to multiple disease processes. This illustration shows the anatomic structures in the anal rectum. The anal canal extends from the rectum to the anal verge or anus. Midpoint in the anal canal is the dentate line, at which you can see vertical folds of mucosa called columns of Morgani, which serve to help identify this area. The internal and external anal sphincters surround the anal canal. The internal anal sphincter, or IAS, is a continuation of the circular smooth muscle of the rectum. It is composed mainly of slow-twitch muscles that resist fatigue. This contributes to its ability to maintain a tonic contraction, thereby assisting with closure of the anal canal at rest. The external anal sphincter, or EAS, is composed of both striated skeletal muscle and smooth muscle and overlaps the internal anal sphincter. This striated muscle of the external anal sphincter can be voluntarily contracted or relaxed. It is innervated by the somatic fibers of the pudendal nerve, which exits the spinal cord at S2, S3, and S4. A gentle stroke with a finger or cotton swab at the 3 and 9 o'clock positions around the anus will elicit what's called an anal wink. This is an observable, quick contraction of the external anal sphincter and indicates the pudendal nerve is intact. The muscles that control fecal continence make up what are known as the pelvic floor and include the endopelvic fascia, the levator ani complex, and the perineal membrane and external anal sphincter. The endopelvic fascia is the first layer of the pelvic floor. It is made of collagen, elastin, and smooth muscle and provide anchor to the bony pelvis. The second layer and principal support for the pelvic floor is the levator ani complex. It is made of small muscles that include the iliococcygeus, pubococcygeus, and puborectalis muscles. These work together as a single unit. The third supportive layer of the pelvic floor is the perineal membrane and anal sphincter. The perineal membrane is a triangular, fibrous structure whose function is to limit the descent of the pelvic organs by attaching the perineal body to the pubic bones. The perineal body is the fascia muscle tissue that separates the distal vagina and rectum to the pubic bones. The perineal membrane also supports the perineal body when the levator ani muscle is relaxed during defecation, urination, and childbirth. As stated on the prior slide, the levator ani complex consists of iliococcygeus, pubococcygeal, and puborectalis muscles acting as a single unit. These muscles stretch across the pelvis and form a diaphragm that lifts the anus, vagina, and urethra and pulls them forward. This provides a compressive force against the lumens of these organs that promote closure through increased pressures. Think of this group of muscles as acting like a sling around the anal-rectal junction. At rest, a 90-degree angle is formed between the anal canal and the rectum. With straining, this angle widens to 135 degrees to assist with the evacuation of stool. The levator ani complex is innervated by the tahi pudental nerve, which is prone to stretch injury during vaginal delivery or pelvic surgery. This muscle group has type 1 or slow twitch muscle fibers as its primary component. This provides sustained muscle tone over a period of time. Type 2 or fast twitch muscle fibers provide strong contractions over a short period of time. These are muscle fibers that come into play when there is increased intra-abdominal pressure, which occurs with sneezing and coughing. The colon, sphincters, and pelvic floor have three types of innervation to regulate its function. The three types include central nervous system control, which is the brain and spinal cord, parasympathetic and sympathetic branches of the autonomic nervous system, and the enteric nervous system, which is the part of the nervous system fixed on the wall of the colon, often called the second brain. The enteric nervous system has two primary plexuses, the myenteric plexus and the Meissner plexus. The myenteric plexus, also known as Auerbach's plexus, lies between the muscles of the colonic wall and has primary responsibility for colonic movement, both mixing or haustral contractions and peristaltic waves or propulsive contractions. The Meissner's plexus is located in the submucosal layer of the colonic wall and is responsible for sensing luminal content, regulating gastrointestinal blood flow, and regulating epithelial cell function. This system contains sensory and motor neurons as well as interneurons, which allows for communication between the sensory and motor neurons. The autonomic nervous system has two nerve fibers, sympathetic and parasympathetic. The sympathetic system has an inhibiting effect on the gastrointestinal tract activity, reducing both secretion and motility. On the other hand, the parasympathetic system promotes peristalsis and secretions. Somatic nerves provide for awareness of rectal distension and accurate identification of the rectal contents, such as gas, liquid, or solid stool. When enough stool is present in the rectum, rectal distension and the defecation reflex is stimulated. This stimulation results in a reflexive or autonomic contraction in the rectal sigmoid, relaxation of the internal anal sphincters, and contraction of the external anal sphincters. This allows for what is termed as sampling, which is allowing a small amount of rectal content to enter the top of the anal canal without leakage. The sensory nerves in this area will alert the individual to the presence of the liquid, solid, or gas rectal contents. This message is then transmitted to the spinal cord, up to the brain, where a decision can be made. Either it's time to head to the bathroom, or you can defer or wait. If it is decided to defer or wait, the external anal sphincter is contracted volitionally, which causes relaxation of the rectal wall, causing reduced intrarectal pressure and decreased sensation of a need to defecate. Pain or the fear of pain may also inhibit the defecation reflex. This can occur in individuals with fissures or hemorrhoids. In review, the physiology of continence and defecation is a complex entity. The internal anal sphincter and external anal sphincter produce high areas of pressure which keeps rectal contents from escaping. Resting tone is provided by the internal anal sphincter, which is under autonomic or involuntary control. The levator ani complex, of which the puborectalis muscle is one part of, provide compressive element to the anal canal at about midpoint. At rest, an angle of about 90 degrees is present. The external anal sphincters, which is under voluntary control, can be contracted volitionally for about 1 to 3 minutes maximum. This is enough time, though, to interrupt a contraction and cause relaxation of the rectum, allowing the urge of defecation to pass. In the first pictogram, you can see demonstrated the acute 90-degree angle that is present at rest from the sling effect of the levator ani complex. With sensory perception of stool and rectal distension, the internal anal sphincter is open and the external anal sphincter is relaxed, decreasing sphincter pressure. The puborectalis muscle relaxes, which straightens the angle, allowing for passage of stool with relative ease. The lower pictogram illustrates the angle that occurs with a sitting posture and a squatting posture. Squatting or sitting with legs supported on a footstool or similar type device can be helpful in straightening the anal rectal angle. In review, sampling occurs as follows. Rectal distension causes a reflexive or autonomic relaxation of the internal anal sphincter. This allows a small volume of rectal contents to go further into the anal canal. This allows the sensory nerves to distinguish whether the rectal contents are solid, liquid, or gas. At the same time, the external anal sphincter is both tonically and volitionally contracted. One then gets a sense of urgency about the need to defecate and what is occurring, again, gas, liquid, or solid, and allows you to make a decision as whether the need to defecate is near or can be postponed. After sampling occurs, higher pressure in the anal canal pushes the contents back into the rectum. Fecal continence is multifactorial, and all of the factors noted here on the slide play an important role. We have already discussed the anal sphincter mechanisms, so now let's discuss some of the other factors. Intestinal transit time refers to the time it takes food to travel from the mouth to the anus. The upper limit for average transit time is about 72 hours, with children being a bit faster at 57 hours. Stool volume and consistency is greatly affected by transit time. As transit time increases, it takes longer for the stool to reach the anus, causing constipation. When the transit time is shortened, diarrhea will occur. Factors that increase transit time would include protein-rich meals, age over 65, and alcohol. Decreased or faster transit time can result from coffee consumption, fatty meals, and some disease states that increase the osmotic load, such as lactose intolerance. Loose stools are associated with decreased transit time as the stool has less contact time in the gut and less fluid is absorbed. With increased or slower transit time, more water is absorbed from the stool, creating a smaller caliber and drier stool. The continence mechanism works best with formed but not dry stool. Normal defecation ranges from 3 times per day to 3 times per week, as long as the individual does not have to strain and does not have pain or incontinence. One has to be able to recognize rectal filling and accurately determine rectal contents in order to have normal defecation and continence. An intact central nervous system, stretch receptors, Sensory receptors in the anoderm and neurologic pathways are critical to maintaining normal defecation and continence. In addition to obvious neurologic problems, overdistension, such as is seen in children with retentive encopresis or adults who have chronic constipation or impaction, have a blunted ability to sense rectal fullness, resulting in problems with continence. Individuals who consistently defer the call to go may also blunt their ability to accurately sense rectal fullness. When the internal anal sphincter is damaged, the likely result is incontinence of gas and liquid stool. When denervation or injury to the external anal sphincter occurs, individuals usually have urge incontinence. That is, the individual knows there's something to be held back and just can't do it. This is particularly difficult with mushy to liquid stool. Complete fecal incontinence or involuntary passage of formed stool can occur if the external anal sphincter is significantly or totally denervated or disrupted. Rectal factors include compliance, which is the ability of the rectum to distend when filled with stool and store the stool at a relatively low pressure, very much similar to that of compliance with the bladder. When the external anal sphincter returns to a resting state, the intrarectal pressure must drop to a pressure less than the anal canal pressure in order for an individual to remain continent. This requires a rectum that has stretch or compliance and adequate capacity. An example to understand this is the way a balloon is able to distend with increased air and then relax again when the air is let out. Rectal capacity ranges from 250 to 500 milliliters, and sensory awareness can occur anywhere from 11 to 68 milliliters. Once capacity is reached, defecation becomes imminent. Increases or decreases in rectal capacity or compliance will place an individual at risk for bowel dysfunction or fecal incontinence. In some diseases, such as ulcerative colitis or after radiation therapy, the rectum loses its ability to be compliant and it acts as a conduit or pipe rather than a holding tank, so continence becomes much more difficult. Other factors that may affect defecation and continence include age, gender, posture, and cultural norms. We have discussed squatting. With squatting, the anal rectal angle straightens, allowing stool to more easily pass from the rectum to the anal canal. Culture plays a part in the position one takes when defecating. In Africa and Asia, individuals normally squat over a hole or low receptacle, while in Western areas, use of a toilet is the norm. Other factors that may affect defecation include psychological disturbances, a history of sexual abuse, coercive toilet training, and dietary intake and medications that reduce the gut motility. Infants respond to rectal distension with expulsion. It is interesting to note that the rectal anal inhibition reflex is not present in premature infants. Infants between 2 weeks and 5 months of age have 1 to 7 stools daily. Preschool children have stool frequency comparable to adults. External anal sphincter control is developed enough at approximately age 2.5 years for bowel training to begin. Most children have total bowel control by age 4 and waking hour bowel and urine control by age 3. Children develop bladder control prior to bowel control. Now, encopresis is fecal soiling that is usually associated with functional constipation. That is, constipation that does not have an organic or anatomic cause. Encopresis occurs more frequently in males than females, with prevalence rates reported to be about 5 to 10%. Primary encopresis refers to a child after 4 years of age who has never gained sustained bowel continence. Secondary encopresis refers to children who have attained fecal continence for at least 1 year but have regressed secondary to another problem. Retentive encopresis occurs in a child with functional fecal retention with overflow soiling. It is clearly associated with constipation. One hypothesis states that as children pass through critical developmental stages, something occurs that contributes to functional bowel disorder. This may be immature bowel function, aggressive toileting, birth of a sibling, or poor dietary habits. A vast majority of these children have functional constipation as a result of chronically retained stool. As the rectum distends, the child is unable to distinguish the rectal fullness because the fecal lith is in the rectum. The internal anal sphincter remains open, which allows small amounts of liquid stool to bypass the fecal mass, resulting in multiple odorous, thin, ribbon-like, or diarrhea stools. Encopresis results in major negative effects on self-esteem and relationships within the family and friends. Medical management begins with education and reassurance to both child and parent. Cleaning out of the bowel is important so as to eliminate all retained stool. Bowel training, which we will discuss in more detail in the management module, is instituted. Medications, in particular laxatives, are given during the bowel training and used for a minimum of 3 months and up to 6 months as needed. Psychological support is important in order to help the child and family deal with any psychological issues that are present. Let's take a moment to look at the statistics listed on this slide. They are a bit intimidating. Remember that maintaining continence is a complex process. An individual has to have intact sensory systems, motor ability, and adequate reservoir capacity. All three areas, sensory, motor, and reservoir capacity, need to work correctly and in concert with each other for a person to be continent of stool. So now let's look at some reasons why individuals become incontinent. Sphincter denervation may be the result of trauma. There may have been a surgical incident, accidental injury such as an impalement injury, and denervating injuries such as occurs with a spinal cord lesion or obstetrical injury in which the pudendal nerve is stretched, resulting in diminished external anal squeeze pressures. Also implicated may be diabetes mellitus, radiation proctitis, and inflammatory bowel disease. Anatomic abnormalities may result from tumors, rectal prolapse, obstetrical injuries, surgical trauma, accidental injuries, third-degree hemorrhoids, fistula, abscess, or perianal disease, and congenital malformations of the anal rectum, such as imperforate anus, as seen in the photograph on this slide. Neurologic impairments includes those that affect the central nervous system, such as stroke, encephalopathy, and degenerative cognitive problems, as well as peripheral nervous system impairments, which would include toxic neuropathy, cauda equina lesions, and diabetic polyneuropathy can also lead to bowel dysfunction and fecal incontinence. As discussed earlier, decreased capacity and compliance limits the reservoir function of the rectum and leads to urgency with small stool volumes. Processes that can result in reduced rectal compliance include malignancies, rectal fibrosis, rectal ischemia, Hirschsprung's disease, fecal impaction, as chronic delay to the signal to defecate leads to a megarectum. This causes excessive compliance and decreased sensitivity to the distension. Also proctitis, which is a result of inflammatory, infectious, or radiation-induced cases. Abnormal delivery of feces to the rectum occurs as a result of celiac sprue. Infectious diseases such as influenza or food poisoning, short bowel syndrome, and inflammatory bowel disease such as Crohn's or ulcerative colitis. Abnormal fecal delivery may also be caused by metabolic issues such as diabetic diarrhea or severe lactose intolerance, or can be drug-induced as the result of medications such as cathartics, antibiotics, or chemotherapeutic agents. Individuals with enteral feedings or malnourishment may have atrophy of the intestinal villi, which can also result in diarrhea. Muscular and neuromuscular disorders include perineal descent, myasthenia gravis, congenital hereditary myopathies, or may be idiopathic, which basically means we just don't know why. Some individuals with profound psychiatric disorders may also become incontinent. And we have already discussed encopresis. To be diagnosed with irritable bowel syndrome, one has to have recurrent abdominal pain or discomfort that lasts at least 3 days out of the month in the last 3 months, and is associated with 2 or more of the above symptoms. It is believed that irritable bowel syndrome is a result of an interaction of multiple factors, including increased gastrointestinal permeability, abnormalities in the gastrointestinal microbiota, altered immune responses, dysfunction of the autonomic nervous system, altered bile acid metabolism, and psychological distress. Diet has not been shown to have a causal relationship, although individuals with irritable bowel syndrome have more food intolerances. A careful and thorough history and physical is required. Treatment is dependent on the predominant type of irritable bowel syndrome presenting, that is, constipation predominant, abdominal pain, or diarrhea dominant. Treatment includes patient education, dietary modification, routine exercise, stress management, and medication including psyllium products, osmotic laxatives, and medications such as lubiprostone or linaclotide, which work in different ways to speed stool through the system. Short-term antidiarrheal medications can also be used. Antispasmodics may be used as an as-needed basis to help with relief of cramping and abdominal pain. Probiotics may also be beneficial, but treatment parameters have not yet been established. This ends our lesson on etiology of fecal incontinence. For more information, please review the references listed on this slide, and thank you for your attention.